Happy to be joined by Dr. Lee Shulman now, the professor of OBGYN and the director of clinical genetics at Northwestern University. Welcome.
Great to be here. Thank you.
Let's talk about this debate about genetic screening. Kind of give us an overview of the pros and cons, both sides.
Sure. First of all, it was really wonderful to do this with Mary Norton. Mary and I have known each other for a while. Mary and I are both OBGYN geneticists, and we both recognize that the increasing application of genetics in both on the prenatal side, which is what we addressed here, but really in all obstetrics and gynecology, is becoming more and more of a challenge for the obstetrician gynecologist who has likely not had a considerable amount of training in this, and it becomes incredibly confusing. The debate today really centered on which approach doctors should consider using when they screen their patients prenatally, hopefully before conception, for genetic disorders like Tay-Sachs, like cystic fibrosis. The college has come out and basically said there are several approaches, all of which are appropriate to use. And so their guidance doesn't necessarily provide a best test to use. Leaving it to us, leaving it to all the fellows of the college to make a decision on how to approach this. Today's debate, Dr. Norton went ahead and took the side of a more limited approach to this, an ethnic-based approach to this, having a smaller panel. My side of the debate was to advocate for an expanded panel. We both had the obvious numbers, good numbers and bad numbers. We overstated our good numbers, we understated our bad numbers. But I think that there are certain things for the people in the audience that heard this. First of all, it is a challenge. It is becoming not so much more and more confusing, but more and more daunting as the number of conditions that we can provide screening for increases. And what that means for care. There were actually a lot of things we didn't go through in this. The molecular technologies that are available, we both alluded to. But some conditions that may have other non-reproductive implications. So it's a daunting challenge. I give a lot of credit, not just to Dr. Williams, but to ACOG for putting this on, because it really does represent a recognition of the clinical challenges that our fellows are facing, and trying to get them the information and the support so that they can make good decisions about the care they provide their patients.
So you mentioned the challenge that OBGYN gets this information. What does he or she do with it? What are the challenges around that? Well,
the challenges are, and it's interesting that both Dr. Norton and I did not do our presentations discussing them with each other. We both had a slide that talked about the Wild West, because out there it is the Wild West. There really are very few rules and regulations, lots of labs offering lots of tests. I guess in a nutshell, Dr. Norton and I are OBGYN geneticists. There are not a whole lot of us in the United States, several dozen at most. So not every hospital has an OBGYN geneticist that they can go to. But they should have a genetic center that has counselors. And my recommendation, actually we both spoke to people after the debate, was to contact your geneticist, talk to them, have a discussion with them, whether it would be with the counselors, with the geneticists, with the genetic service provider that they use. Talk to them about the approaches to screening, and at the end of the day, no matter which one they decide, limited, not so limited, expanded, that they decide on a laboratory process that they would apply to all of their patients in a consistent manner. I made the statement that I use a lot of, it's just screening. What I mean by that is that a screening process is not 100% accurate. It identifies people at risk. So it's going to unfortunately miss some people who are actually at risk. It is also going to identify some people to be at risk who are not at risk. That is inherent in the screening process. But whatever one you use, there's going to be good things about it, there's going to be drawbacks about it, That's recognized in the screening process, but that's the process that you use as you go forward and you offer it consistently to your patients.
Would one of the solutions be, you mentioned that standardized, maybe per hospital, but are we talking about statewide or nationally? Are we heading?
Well, states have for the most part stayed away from this, and that is probably a good thing in the long run. It becomes very difficult for governmental agencies to start standardizing, especially changing technologies. Hospital systems, though, have gotten to choosing a laboratory and a process to cut costs. There are benefits to that, but there are clear detractions to that because, again, a single laboratory is going to have good things about it. It's going to have not good things about it. So there has been an attempt to do that, but in a very real sense, it's that mercury ball. You squeeze it, you think you catch it, and then it squirts off, and there's another issue. This is a rapidly changing technology. I mentioned this. My counselors and I meet 2 to 3 times a year to go over our panel. We have a panel that consists of 176 conditions. We add some, we take them off. There are certain criteria that we use for inclusion or exclusion. In fact, we have our next meeting in 2 weeks, and we spend a couple of hours going through what we have, changes, whatever. And they're all evidence-based changes. We all get homework assignments to promote a particular gene to be added or to promote the exclusion of a particular gene that's already in the panel.
What do you hope people who saw the debate, who see the debate, take away?
I hope that they understand, first of all, that this genetic technology is a part of routine obstetrical care and is going to continue to be a part of routine obstetrical care. That they perhaps look at this in a more sober manner. Not so much as which lab is coming in or whatever, but to sort of understand the implications or perhaps get a greater understanding of the details of this. And that also, on the other hand, to reassure them that whichever one they choose, laboratory, process, genetic service they choose, that they accept that it will be, all the laboratories are CAP/CLIA approved laboratories, so the quality is there. But that they then take that and apply that in a consistent fashion to their patients. And I guess the last thing that we alluded to is that they empower their patients. The issue isn't that they need to talk their patients into testing. The issue is they need to empower their patients to make decisions. I tell my patients, I ultimately don't care what their decisions are. I want them to have the information to make a decision that's right for them.
Dr. Shulman, thank you very much for all your insight on this.